Scaphoid compression grind, Phalanx. Okay. Okay. You can do these pretty much on yourself.
Yeah.
And just the person sitting next to
Yes.
you. We don't have to, get into other tables for this. So, Finkelstein's is a muscle length test for the posterior compartment, which is the extensor pollicis and abductor pollicis. You're gonna cover the thumb and then ulnarly deviate. Technically, the test is passive, but everybody that I know just has the patient just do it. And if you do that, you should feel a little bit of tension, but not pain. And they'll feel it here. And if that's positive, that means they have a tenosynovitis or a tendonitis of either their extensor or their abductor pollicis or both. And you can do some, I find it's usually due to a CMC hypermobility. So when you get into the CMC joint, they're going to be hypermobile in one or multiple directions. And that muscle is working overtime to kind of hold it together. The other time I see it is patients with poor posture, and they have a C6-7 issue, and that's causing C6 radiating pain, which is down through here. We sensitize the muscle, you get muscle guarding, changes the tone, and then you get a tenosynovitis as well. All right. Finkelstein's. Then we have other treatments for that. Let's tie exam to treatment. So you can do some light soft tissue to the thumb. You do your grade 2 oscillations. Okay. Remember, when you're treating pain, the direction doesn't matter. And then you would do active extension and active abduction. 3 sets of 30, 3 sets of 40 at 50% of 1 RM for tissue healing as well as for vascularity to this area, this muscle in particular. And then you could, if it was a true tendonitis, you could do opposite motion for eccentrics. So you could have the rubber band, just a little office rubber band on the thumb and do flexion or do adduction, because if you do the opposite motion, you get eccentrics. And that's how I would treat a tendon. If it was just tendon irritation due to like muscle guarding, I would just really focus on the concentrics. And then if they have a CMC joint hypermobility and you're a PT, you can send them over to your CHG friends and have them make a little thumb immobilization spica splint or whatever they want to do, and just get an immobilizer. Sometimes you can just get them off the shelf. They make the nice Velcro ones that cover the wrist. I don't know if you guys like that. I know you have an opinion, so please take the floor and tell me what you like.
For the hypermobility customer over the counter,
Yeah.
we choose usually the cheapest option for the patient.
Good. Especially today, in today's world. All right. Finkelstein's. What's next on the list there? Scaphoid compression grind. So sometimes this is positive with Finkelstein's, especially if they have a CMC as their underlying problem. You're just going to take the patient's thumb and just jam it down and move it around like that. That's the grind test. And you're looking for audible grinding, feeling of grinding. You can feel it, you can hear it sometimes, and then it should be painful. So that's like your typical cartilage test. Okay. What was the third one on the list? Phalanx and reverse phalanx. Okay, Phalanx is going to compress the carpal tunnel. You're looking for symptoms in these 3 fingers. Okay. Reverse phalanx is the prayer position. Okay, you're going to hold that for 30 seconds. That tightens the retinaculum, which then causes a compression. This actually gets compression from the radiocarpal joint, specifically the lunate. So you're looking at compression of the carpal tunnel. It's rare you're going to have a carpal tunnel without a neck problem. So make sure you're treating the cervical spine with your thumb injuries, with your neck injuries. So we'll practice. We'll do some cervical work this weekend as well. All right. Then you had Frohman's sign and Frohman's pinch. So you're going to take a piece of paper, and Frohman's pinch is median nerve, which is the OK sign. You should be, if you you can pull the paper out, or if they do this, which is cheating, so that means they have a flexor pollicis, brevis weakness, which means they may have a median nerve issue, or they could just have flexor pollicis, brevis weakness. You can do Tinel's or any of the other carpal tunnel tests to determine that. Froment sign is the adduction. So remember, your adductors start over on the ulnar side and come over to the pollicis, so it gets its innervation from the ulnar nerve. So this is for ulnar nerve, and you're gonna pinch the paper here, try to pull it out, and it's that motion, your stop movement motion. Okay. Interestingly, the branch to the adductor is just motor only. So a lot of times if that's compressed, you're not gonna have tingling or numbness, you're just gonna have weakness. So just know, if you got adductor weakness, you're not gonna pick it up because they have pain or tingling. The median nerve you will. They're gonna be like, these 3 fingers fall asleep at night, okay? All right, Tinel's is you can tap anywhere over a superficial nerve. For the carpal tunnel, you're gonna be distal to the tunnel right there, right around there. Okay, don't tap over the tunnel. I learned it around my PT school as well, so just tap there. 30 seconds, you can do ulnar nerve at hook of the hamate. Okay, tingling into these 2 fingers, median nerve's gonna be these guys, ulnar nerve these guys. All right, did I miss anything? Oh, supination lift, that's simple. If they got ulnar joint line pain, you should be thinking TFCC or ulnar collateral ligament, and they're just gonna do lifting on the table, and that should hurt in the ulnar side of the joint. Okay, now we got for a TFCC tear. All right, and then Bunno-Littler. Is there anything other than Bunno-Littler? Okay. The Bunno-Littler test is testing for what's limiting the PIP joint. So they have a PIP joint limitation. You can take the finger, extend the MCP, and flex the finger, and they should be more limited in that position than this position. Okay, because this is stretching lumbrical. So if that's more limited than this, they probably have lumbrical tightness. If the PIP joint is limited in both spots, they got a PIP joint mobility issue. How does that affect your treatment, which is the point? Well, if they have lumbrical tightness, you got to do the testing to treatment. You're gonna stretch the lumbricals like that with the MCP joint extended. Okay? If they just have finger like PIP joint tightness, you're just gonna do volar glides of the PIP joint. Distraction of volar glides. All right. Elbow. I don't think there's much at the elbow. Compression and distraction test. Do you mind being my model? Just slide down here. These also double as like joint mobility assessment. If you could just like turn it this way. The other way. Face me. Appreciate it. Okay. So you're gonna be here, line up your forearms, you're compressing, or you're doing this 3-finger grip here, and you're distracted. You guys can practice this, okay? Both can hurt or relieve symptoms. Okay, let's start with compression. If this hurts, you're thinking compression. So some kind of radial head problem. Either radial head cartilage, radial head fracture. If you're thinking fracture, you can use a tuning fork and see if in lieu of an x-ray, you can use a tuning fork. I usually use a tuning fork down here, and if it recreates pain at the radial head, they probably have radial head compression fracture. That would be like falling out, stretch arm. Okay? If compression feels better, they probably have a subluxed radius, which happens when the arm gets yanked. They call this nursemaid's elbow because like you're yanking your 8-year-old at Disney because they're not listening. Okay? All right? And then that would be a ligamentous injury, so you do a lot of treatment of the muscle guarding, so soft tissue, grade 2 oscillations of the radial ulnar joint, and then you do a lot of pronation, supination, 3 sets of 25 for coordination. Then distraction is the same exact test, but now you're doing it opposite. So if this hurts, you have a subluxation, treat it like I just talked about. If this feels better, you have a radial head cartilage or bone problem. Figure out if it's a fracture, they gotta have surgery or immobilized. If it's just cartilage irritation, you can treat it with a lot of 50% exercise, which would include flexion, extension, supination, pronation. All right, other elbow tests. What do we got? Right here. Oh yeah, varus valgus. Okay. So, can you stand for me? Okay, face me. Good. So again, you want this on the side of your arm. Don't think about what you're doing. Just put it down, and then just look down. This is going this way. So I'm not doing, varus valgus test is across the joint, right? So how can I do across the joint? I gotta do something weird with my arm. So this is, you can see I got my hands like this. So my right hand or my left hand is in position right now to push across my left hand. So outside is varus, so you do it at 0, you do it at 30 to get both parts of the joint capsule and ligament, and then you just switch sides and now I can do my valgus. Okay. Because of your carrying angle, your valgus test is usually the one that's positive. Your varus test typically is tight, especially with people that have chronic extensor tendonitis. What's the healing factor is inflammation, so that gets extra scar tissue there, and your varus test is usually tight if it's pathological, and your valgus test is usually loose. Your Tommy John surgery or MCL sprain, that's your medium. Okay. We practiced. I think we practiced. Did I show you the lateral elbow minute last time? Did we do it as a thrust?
No.
We didn't do it as a thrust. Okay, we'll do it this weekend. But we did the lateral. You can use the varus test as a treatment. You can gap the lateral side to stretch the soft tissue. So that's pretty cool. One thing I want to review before you practice. You're going to practice compression. You'll practice the compression, the distraction test, and the varus and valgus test. If this is the forearm and this is the humerus, okay? When we're doing glides, which we'll practice later, you want to be blocking each one. So I'm going to have one hand on the humerus and one hand on the ulna, and I'm going to be doing a glide. When I'm doing a gap technique, I actually have one hand on both, because when I push, I get this bending out. So make sure your hand for varus and valgus are over the joint line, so when you push, you get a bending out on the other side. And then when we practice, we talked about this a lot last time. When we do joint gliding, medial and lateral, you don't want the bend. You want it to glide like this, so your hand has to be just on the ulna or just on the radius to do the straight glide, medial lateral. That makes sense? Yeah, remember that? Okay. So for the varus and valgus, your hand's gonna be over the joint space. So when you push, you get the bending out, which will stretch the capsule ligament. All right? So let's practice varus valgus compression distraction.